Okay, so we talked about 2 agents. I think
There's more.
there's more.
But wait, there's more. Yeah, so a couple of the other ones, I think, we've all been a little bit enamored with the gemcitabine pretzel, the TAR-200 agent. That one's it's such a neat delivery device. And so they've looked a little bit, most of the work, and that's from the Sunrise trial, has been done in the BCG unresponsive space. There are ongoing trials to look at, what kind of role would this have? And to me, this is the ideal group because this is the people who are already low-grade disease, is the people we're already giving gemcitabine to. So this to me is like, hopefully good data will come out of here and we can kind of get this one up and running. Practically, it's exchanged every 3 weeks during treatment. And so, that's a nice, less time-consuming option for patients where they can get a sustained exposure to the drug without having quite so many visits. I know our patients are coming from far away frequently, and so getting this and having them tolerate it would be really helpful. So
Yeah,
I think
absolutely.
this one's also pending FDA review. So there's a couple of things that are at the FDA right now that have had new drug applications submitted, and it's just a matter of kind of watching it go through that process. But we're eagerly awaiting some of those.
Yeah. And I think the interesting thing about this device specifically is it's a drug that we have understanding and experience with. And so although it's a new delivery system, that delivery system is important for convenience, as you alluded to. But at least we can talk to our patients about the fact that it's a drug that we know it's tried and tested. There's ongoing trials more in the gemcitabine versus BCG space, of course. But when we're talking about low-grade disease, we have experience to lean on.
Yeah. And so it's helpful to have that data and we can talk to patients about it. We know it works. And so, yeah, I think it's this to me is an ideal spot for this agent.
Yeah. It seems like there's a flurry of agents, obviously, as it relates to intermediate risk, also high risk. It can get really confusing. It's, for those of us who even are urologic oncology trained, I think it's going to be challenging to figure out who is appropriate for which agent. So I'm just curious, for your thoughts in general. I know we're still waiting on approval for some of these drugs, but as you think about the overview we just discussed, what's sort of the triage mechanism in your head, and maybe different considerations from a quality of life perspective that we can use to make these decisions with our patients?
Yeah, I think thinking through what people can logistically get is probably the most important. I'm always a little bit surprised by how patients do with some of these drugs that we give. I mean, you have people who have just terrible lower urinary tract symptoms, and I think sometimes it's from the cancer. I had a gentleman who had a lot of high-grade TA disease and a lot of CIS, and so not intermediate risk population, but he got treated with BCG, and finally, towards the end of BCG, he actually, I think, had some control of his disease and started feeling a lot better. And his lower urinary tract symptoms actually improved on BCG, which is not something we frequently hear. I'm like, okay, well, that makes me feel like this was probably the cancer causing your lower urinary tract symptoms. But so I think some of those considerations, in my mind, I think that a lot of the lower grade tumors tend to respond a little bit better to the chemotherapy agents, and the higher grade tumors seem to respond a little bit better to some of the more immune-mediated treatments. And I think we see that a fair bit with the data when we look at, some of the folks who have the best responses are people with CIS. It's very effective. And so it makes me think that, there's some mechanism there of why that occurs. And so I rely heavily on pathology and what I see at the time of, cysto and TURBT. And I tell patients too that, we're going to try this one thing. And if it doesn't work, we have a lot of things in our toolbox to try next. And just because you have a terrible reaction to one thing doesn't mean that we have to take your bladder out. We can try something different. I think that they need that reassurance because it's a lot for them to go through. And I do keep cystectomy in the back of my mind, less so for low-grade patients. I would hate to take a bladder out in a patient with low-grade disease. But eventually you sit back and you look at this, and if they've gotten, induction BCG, all the surveillance, any form of maintenance, and then you give them induction, something else, it's another, 6 weeks, and they've been in your office, a lot, and driving back and forth and taking time off work. So I try to be cognizant of just, keeping keeping things on the table, letting them know that there's hope with some of these other agents that we can try. I also feel like a lot of patients think, oh gosh, I was totally tortured by BCG. It must have worked. And I'm like, nope, like how you tolerate it doesn't at all correlate, unfortunately, with whether you responded to it or not. So I think just being open and honest with them. But I think about what it's like for them to come for treatments, because it can be time consuming. So for folks who are really far away, something where you can do it once every 3 weeks, that offers a better quality of life for people who are driving far distances. We try to partner with people in the community to see if we can get folks BCG and other agents. Some cancer centers and infusion centers are really willing to help with some of our gemcitabine docetaxel delivery. I know there's a bunch of folks looking at kind of in-home, like home health nursing, basically administering BCG, some of the newer agents, UGN-102 is one of them, and just seeing the feasibility of that. And people are like, they're able to do it. So I think, there's a lot on the horizon with trying to find new delivery methods in addition to new delivery systems that are a lot more convenient for patients.
Yeah, absolutely. I mean, I know you know this better than most of us, but there's such a shortage of urologists, particularly in rural America. So figuring out novel ways to get patients in-home treatments, it's going to be really, really important.